Hi all. Today we are going to discuss about Tnm staging of different cancers. Let's dive into all each malignancies according to the Tnm staging based on AGCC 8th edition and Sabiston 21st edition. So for esophageal cancers, TIS is migraine dysplasia, T1A is lamina propria or muscularis mucosa, T1B is submucosa, and T2 they will invade into but not beyond the muscularis propria. T3 invades adventitia, it has no serosal layer. T4A invades adjacent structures that are usually resectable. It could be a diaphragm, pleura, acetasphyne, peritoneum, or pericardium. T4B invades structures that are usually unresectable, like aorta, vertebral body, and trachea. So regional lymph nodes, NX, it cannot be assessed. N0, no regional lymph node mets. N1, mets in 1 to 2 regional lymph node. N2, 3 to 6. N3, more than or equal to 7. M0, no distant mets. M1, there is distant mets. GX grade cannot be assessed. Well differentiated, moderate, and poorly differentiated. The Tnm staging of colonic cancers. The Y prefix refers to the neoadjuvant radiotherapy or chemo-RT. P refers to pathological confirmation of staging. So T1, the tumor which invades into submucosa, so not lamina propria or muscularis mucosa, directly submucosa. T2, muscularis propria. T3, non-peritonealized pericholic tissues of subserosa. T4A, tumor breaches visceral peritoneum. B, invades other organs or structures. N0, no nodes involved. N1, 1 to 3 nodes, which is N1A, 1 regional lymph node, N1B, 2 or 3. N1C, satellite extranodal tumor deposit. N2, 4 or more nodes involved. N2A, 4 to 6. N2B, 7 or more. M0, no metastasis. M1, metastasis. In that, M1A, metastasis to one organ. B, more than one organ. M1C, metastasis to the peritoneum. Just have a look here. T3 is non-peritonealized pericholic tissues. M1C is metastasis to the peritoneum. This is the basic difference. And T4A, if it breaches visceral peritoneum. So the Tnm staging of colonic cancers completed, and now moving on to CA stomach. So T0, no evidence of primary tumor. TIS, carcinoma in situ intraepithelial tumor without invasion of lamina propria or high-grade dysplasia. T1 invades lamina propria, muscularis mucosa, or even submucosa. So in that, T1A, tumor invades lamina propria or muscularis mucosa. T1B, submucosa. T2, tumor invades muscularis propria. T3, tumor penetrates subserosal connective tissue without invasion of the visceral peritoneum or adjacent structures. If once breaches visceral peritoneum, it is T4A. If it invades adjacent structures, then it is T4B. N1, 1 to 2. N2, 3 to 6. N3, 7 to 15. N3A. N3B, 16 or more. M0, no distant metastasis. M1, distant metastasis. Right. And for rectal cancers, TX, primary tumor cannot be assessed. T0, no evidence of primary tumor. TIS, carcinoma in situ intraepithelial or invasion of lamina propria. This is more similar to colonic cancers. T1 invades submucosa. T2, muscularis propria. T3, muscularis propria into perirectal fat or mesorectum. T4A penetrates visceral peritoneum. T4B adjacent structures. N1 1 to 3, N1A 1 lymph node, N1B 2 or 3. N1C submucosal, mesangial or peritoneum covered paracolorectal terminal deposits in the absence of regional lymph node mets. N2 more than or equal to 4 regional lymph nodes. N2A 4 to 6 regional lymph node met. N2B more than or equal to 7. M1A mets to one organ or site. It can be a liver, lung, ovary and extranodal or extraregional lymph node metastasis. M1B metastasis to more than one organ or site. M1C is peritoneal metastasis with or without mets to other organs. A very important topic with respect to the gallbladder cancers. TX primary tumor cannot be assessed. T0 no evidence of primary tumor. TIS carcinoma in situ. T1A in gallbladder there is no submucosa. So thereby T1A invade the lamina propria, T1B invade the muscular layer, T2A invade the perimuscular connective tissue on the peritoneal side with no involvement of the serosa, visceral peritoneum. T2B invade the perimuscular connective tissue on the liver side with no extension to the liver. So here T2A is serosa related, T2B is liver related. T3 is perforate the serosa or visceral peritoneum, or it invade the liver or any other adjacent organ or structure such as stomach, duodenum, colon, pancreas, omentum or even extrahepatic bile ducts. T4 invade main portal vein, hepatic artery or invades two extrahepatic organs or structures. NX regional lymph node cannot be assessed. N0 no regional lymph node mets. So N1 mets to 1 to 3 regional lymph node, N2 4 or more. No distal mets. M1 there is a distal mets present. For soft tissue sarcomas, the primary tumor cannot be assessed as TX. So it's very easy and simple. Tumor less than or equal to 5 cm is T1. 5 to less than or equal to 10 cm is T2. More than 10 cm less than or equal to 15 cm is T3 and more than 15 cm is T4. So no regional lymph node N0, regional lymph node is N1. Right. So the grade is very important. Grade 1 is differentiation. Stage 1A is T1 N0 M0. 1B is grade 1 up to stage 1. T2 to 4, T3 T4 N0 M0. Stage 2 T1 N0 M0. Now the grade is changed to grade 2 and grade 3. 3A is T2 N0 M0 grade 2 and grade 3. 3B is T3 T4 N0 M0 grade 2 grade 3. Stage 4 any T N1 M0 any grade. Next any T any N M1 or any grade. The simple point to remember, if any N, if there is nodal mets, there is metastasis, then it is stage 4. If it is grade 1 and grade 2, then it is stage 1A and 1B. Grade 2 and grade 3, then it will be stage 2 to 4. In that case, stage 2 T1, stage 3A is T2, stage 3B is T3 and T4. So with respect to thymoma staging, T1A is encapsulated or unencapsulated with or without extension into the mediastinal fat. T1B extension into mediastinal pleura. T2 is pericardium. T3 is lung or brachiocephalic vein, so SVC, chest wall, phrenic nerve, hilar vessel. T4 aorta, main pulmonary artery, arc vessel, myocardium, trachea or even esophagus. N0 is no nodal involvement. N1 is anterior thymic node. N2 is deep intrathoracic or cervical lymph node. M0 is no metastatic pleural, pericardial or distant sites. Whereas M1A separate pleural or pericardial nodule. M1B pulmonary intraparenchymal nodule or a distant organ metastasis. The key point to remember here is T3 lung, brachiocephalic vein, SVC, chest wall, phrenic nerve involvement, is T3. Whereas the main pulmonary vessels, the vessels like aorta, aortic vessel, main pulmonary artery, trachea or esophagus, everything comes under T4. There is another one thing called Masoka staging for thymoma. Stage 1, it's a macroscopically completely encapsulated with no microscopically detectable capsular invasion. 2, there is a macroscopic invasion or microscopic invasion into the capsule. 3, a macroscopic invasion into the surrounding organ, pericardium, great vessels, or even intrathoracic mets or both. 4a, pleural or pericardial implant or dissemination. 4b, lymphogenous or even hematogenous mets. So sometimes they may ask you about lung cancers. Keep some points in. So T0 is no evidence of primary tumor. T is carcinoma in situ. T1 is less than or equal to 3 cm. But the tumor is not in the main bronchus. No evidence of bronchoscopic invasion, more proximal than the lobar bronchus. But in that T1A MI is minimally invasive. T1A is less than or equal to 1 cm. B 1 to less than or equal to 2 cm. C 2 to less than or equal to 3 cm. T2 is 3 to more than or equal to 5 cm. So in that case, T3 involves main bronchus. So T1 is not in the main bronchus. T2 involves main bronchus and also visceral pleura. So main bronchus regardless of distance from the carina, but with no involvement of carina. So because of involving the main bronchus, it is associated with atelectasis or obstructive pneumonitis that extends to the hilar region involving part or whole of the lung. But now T2A is with respect to the size 3 to less than or equal to 4 cm, 4 to less than or equal to 5 cm. T3 is 5 to less than or equal to 7 cm in the greatest dimension, or separate tumor nodule in the same lobe as the primary tumor, or directly with any of the following structure. So in this, very important chest wall, that is parietal pleura and superior sulcus tumors. So visceral pleura involvement T2, parietal pleura involvement T3, and superior sulcus tumors. Phrenic nerve involvement T3, parietal pericardium T3. Why this is very important? Look at this. Visceral pleura T2, T3 is parietal pleura and T3 is parietal pericardium. If it involves diaphragm, then it is T4. Either it is more than 7 cm in the greatest dimension with a separate tumor nodule in a different ipsilateral lobe. See, here there is a tumor. So there is a tumor in one lobe, there is a tumor in the another lobe, then it is T4. But if in case tumor is in the same lobe, separate tumor nodule in the same lobe, then it is T3. Or it means any of the following structures like diaphragm, mediastinum, heart, great vessels, trachea, recurrent laryngeal nerve involvement, vertebral body and carinal involvement is T4. So the point here is phrenic nerve involvement is T3 and diaphragm involvement is T4. Right. And heart involvement, which is visceral pericardium, T4. Right. And one more thing. No regional lymph node in N0. N1 is medicine ipsilateral, peribronchial or perihilar and intrapulmonary nodes, including involvement by direct extension. N2 is medicine ipsilateral mediastinal or subcarinal lymph nodes. So hilar lymph node N1. N3 is medicine contralateral mediastinal, contralateral hilar, ipsilateral or contralateral scalene or a supraclavicular lymph nodes. M0 is no distant mets, M1 distant mets present. With respect to the site, M1A separate tumor nodule in a contralateral lobe, tumor with a pleural or pericardial nodule or a malignant pleural or pericardial effusion. M1B single extrathoracic mets, M1C multiple extrathoracic mets in one or more organ. See, the point here is M1A, a separate tumor nodule in a contralateral lobe, whereas T3 is separate tumor nodule in the same lobe. T4 is separate tumor nodule in a different ipsilateral lobe. I just want to emphasize the importance of progression of pancreatic malignancy, from in situ to invasive malignancy. The pancreatic intraepithelial neoplasia, so normal and pan-IN1A is based on the KRAS mutation, and pan-IN1B also influenced by KRAS. Pan-IN2 is CDKN2A or even P16. Pan-IN3 is P53 or a SMAD4 mutation. So what are all the histological changes observed? So in this pan-IN1A, where the nucleus is at the base and the cells are columnar, here the cells are crowded together and the nucleus morphology is altered. The staging for distal bile duct cancer: T1, tumor invade the bile duct with a depth less than 5 mm. T2, invade the bile duct with a depth of 5 to 12 mm. T3, depth more than 12 mm. T4, celiac axis, SMA or a common hepatic artery. N0 is no regional lymph node met. N1, 1, 2, 3. N2, it is 4 or more. A very important one, TX, primary tumor which cannot be assessed. T0, no evidence of primary tumor. DCAS, TAS, TAS Paget's disease. T1 MI is tumor less than or equal to 20 mm in greatest dimension. So T1 MI is less than 1 mm. T1A is more than 1 mm to less than or equal to 5 mm. T1B is more than 5 mm, less than or equal to 10 mm. T1C is more than 10 mm but less than or equal to 20 mm in greatest dimension. So T2 is 2 to less than or equal to 50, 22 less than or equal to 50 mm. T3 more than 50 mm in the greatest dimension. T4A, extension to the chest wall, but invasion to pectoralis muscle in the absence of chest wall invasion will not qualify. T4B, ulceration or ipsilateral macroscopic satellite nodule or even edema of the skin. T4C is T4A and B are present. T4C. D is inflammatory carcinoma, which is a purely orange appearance and redness more than 1/3 of the surface of the breast, with or without a breast lump. So N1 is metastasis to mobile ipsilateral level 1 and level 2 axillary lymph node. N1 MI is micromets, approximately 200 cells, more than 0.2 mm, but none less more than 0.2 or 2.2 mm. This is important because in case of CM0I+, there is no clinical or radiographic evidence of distant metastasis in the presence of tumor cells or deposit less than 0.2 mm detected microscopically or by molecular technique in circulating blood, bone marrow or other non-regional nodal tissue in a patient without symptoms or signs of metastasis. M1, distant metastasis detected by clinical and radiographic means. So CN2A is mets in ipsilateral level 1 and level 2 lymph node fixed to one another or other structures. N2B, ipsilateral internal mammary node in the absence of axillary lymph node mets. N3A is ipsilateral infraclavicular. N3B, ipsilateral internal mammary and axillary lymph node. N3C, ipsilateral supraclavicular lymph nodes. A very important topic, penile cancer. T1, in case of glans penis, tumor invades lamina propria, foreskin invades dermis, lamina propria dortus fascia, shaft invades connective tissue between epidermis and corpora regardless of location. T1A is tumor is without lymphovascular invasion or perineural invasion and is not high grade. T1B exhibits lymphovascular invasion or perineural invasion or is high grade, grade 3 or a sarcomatoid. T2 invades into corpus spongiosum, either glands or ventral shaft with or without urethral invasion. T3 is corpora cavernosum, T4 adjacent structures. The point here is T3 involvement, tunica albuginea. NX, no regional lymph node, regional lymph node cannot be assessed. No palpable or visible enlarged inguinal lymph node. N1, mobile unilateral inguinal lymph node if more than or equal to 2, if palpable and mobile, or bilateral, then it is N2. N3 is fixed or pelvic lymph node, unilateral or bilateral. If it is pathological staging, less than or equal to 2 unilateral inguinal mets with no extranodal extension. N2 more than or equal to 3 unilateral inguinal lymph node met. N3 is extranodal extension of lymph node mets or pelvic lymph node mets. M0 no distal mets, M1 distal mets present. So this is very important with respect to the prostate cancer. So TJX is primary tumor on basis. T0 has no evidence of primary tumor. And T1A is tumor incidental histological finding in a 5% or less of tissue resected. T1B is tumor if more than 5%, the histological finding in more than 5% of tissue resected. T1C is identified by needle biopsy found in one or both sides but not palpable. T2A one half of one side. T2B more than one half of one side but not both sides. C is both sides. T3A extra prostatic extension unilateral or bilateral. T3B in which seminal vesicles. So T4 is tumor is fixed in which adjacent structure other than seminal vesicle, external sphincter, rectum, bladder, levator muscles and pelvic wall. So T2 is organ confined. T3 is extra prostatic extension. So T3A is extra prostatic extension or microscopic invasion of the bladder neck. T3B in which seminal vesicle. T4 is fixed or in which adjacent structure other than seminal vesicle such as external sphincter, rectum, bladder, levator muscles and pelvic wall. So here the TX is the primary tumor cannot be assessed is a testicular tumors. T0 has no evidence of primary tumor. T is germ cell neoplasia in situ. T1A tumor smaller than 3 cm in size. T1B 3 cm larger. T2 tumor limited to testis with lymphovascular invasion present. T2 is also invading hilar soft tissue or epidermis or penetrating visceral mesothelial layer covering the external surface of tunica albuginea. T3 is tumor directly involves spermatic cord with or without invasion. T4 invades scrotum. This is important. So with respect to the lymph node mets, N1 is mets with the lymph node less than or equal to 2 cm. N2 is lymph node less than or equal to 2 to less than or equal to 5 cm. And clinically with respect to the N3 is mets with the lymph node more than 5 cm in greatest dimension. So in case of a pathological staging, NX no regional lymph nodes N0. N1 is lymph node size 2 cm or less than or equal to 5 nodes positive, but less than or equal to 2 cm. So less than 5 nodes, less than or equal to 2 cm. N2 2 to 5 cm more than 5 nodes positive. N3 more than 5 cm. M0 no distal mets, M1 distal mets. So M1A a non-retroperitoneal nodal or pulmonary mets. M1B non-pulmonary visceral mets. A very important with respect to the tumor marker. S0 is marker study levels within the normal limit. S1 LDH is 1.5 times the normal. HCG is less than 5000 units and the alpha fetoprotein is less than 1000. S2 1.5 to 10 times the normal. HCG 5000 to 50,000. AFP 1000 to 10,000. S3 LDH more than 10 times normal or HCG more than 50,000 or alpha fetoprotein is more than 1000 nanogram per ml. So this is mainly for bladder cancer. T0 is no evidence of primary tumor. T is non-invasive papillary carcinoma. Ti is urothelial carcinoma in situ or it can be a flat tumor. T1 is invades lamina propria. T2 muscularis propria. T2A superficial. T2B deep, which is outer of. And T3A microscopic perivesical soft tissue invasion. T3B macroscopic invasion. T4A is an extravesical tumor invades directly into the prostatic stroma, seminal vesicle, uterus or vagina. T4B extravesical tumor or invades pelvic wall and abdominal wall. N1 a single regional lymph node meets in more than the true pelvis. N2 is multiple regional lymph node meets in true pelvis. Lymph node meets to common iliac lymph node is N3. M1 distant meets. M1A distant meets emitted to the lymph node beyond the common iliac. M1B is non-lymph node distant meets. So it's a final catch with respect to the renal cell cancers. T1A less than or equal to 4 cm limited to the kidney. T1B is 4 to 7 cm limited to the kidney. T2 is more than 7 cm less than or equal to 10 cm in the greatest dimension. T2B is more than 10 cm to the kidney. T3A extends into the renal vein or its segmental branches, pelvic calcium system, but not beyond gyrus fascia. T3B IVC below the diaphragm. T3C is IVC above the diaphragm. T4 invade beyond gyrus fascia, including the contiguous extension into the ipsilateral adrenal glands. So this is very important with respect to the oral cancer malignancies. So Tx is primary tumor cannot be assessed. Ta is carcinoma in situ. T1 less than or equal to either T1 tumor less than or equal to 2 cm or depth of invasion is less than or equal to 5 mm. T2 tumor less than or equal to 2 cm with a depth of invasion more than 5 mm and less than or equal to 10 mm. Or tumor more than 2 cm but less than or equal to 4 cm and overall depth of invasion is less than or equal to 10 mm. T3 more than 4 cm or any tumor if more than 10 mm depth of invasion. T4A involvement of the moderately advanced local disease invade through the cortical bone. If it is lip, invade through cortical bone, inferior alveolar node, floor of mouth or skin of face, either chin or nose. If oral cavity invades adjacent structures through cortical bone of maxilla or mandible, involves maxillary sinus or skin of the face. T4B, remember this mnemonic, PIMS. PIMS is very advanced local disease. So tumor invades pterygoid plate, internal carotid artery, masticator space and skull base. So NX is regional lymph nodes cannot be assessed. In that N0 is no regional lymph nodes. N1 mets in single ipsilateral lymph node less than or equal to 3 cm. ENE should be negative. In that case, N2A mets in a single ipsilateral which is contralateral lymph node which is less than or equal to 3 cm. ENE positive. Or 3 to 6 cm. ENE negative. Single ipsilateral lymph node. N2B a multiple ipsilateral lymph node more than 3 cm to less than or equal to 6 cm. ENE negative. N2C bilateral or contralateral lymph node less than or equal to 6 cm. ENE negative. N3A mets in a lymph node more than 6 cm. ENE negative. N3B just mets in a single ipsilateral lymph node more than 3 cm in a greatest dimension with ENE positive, or mets in a multiple ipsilateral, contralateral or bilateral lymph node with any ENE positive. And this one is important. Stage 0 is T is N0 M0. If metastasis, then it is 4C. If it is N3, then it is 4B. If it is T4B, then it is also 4B. T4A is 4A, N0, N1 or N2. Whereas 3 is N0, N1 and stage 3 is N0, N1 and T3, T1 and T2, T3. Stage 2 is T2, N0, M0. Stage 1, T1, N0, M0.